Hello, in this video we're going to look at the clinical anatomy of the spinal cord. Now the spinal cord is part of your central nervous system. The spinal cord is a continuation of the brain and the brainstem. The spinal cord's termination is called the conus medullaris, which ends at about the L2 vertebral level. From this point on you have continuing nerve fibers extending down, known as the coda equina, or the horse's tail. The spinal cord is protected and goes through the spinal canal, which is basically made up of the vertebrae, the bones. The vertebrae is divided into sections. You have 7 cervical vertebrae, you have 12 thoracic, 5 lumbar, you have the sacrum, and then you have the coccyx. Like the vertebrae, the spinal cord is also divided into sections. You have the cervical, thoracic, lumbar, sacral, and coccyx sections. Each spinal cord section segments have nerves coming in and out of it. These are known as the spinal nerves. The spinal nerves exits from their corresponding vertebral level. Let's take a look at the cervical spinal cord, which is unique because it has 8 pairs of spinal nerves. The cervical spinal cord is drawn in green here. And it's unique because the cervical spinal nerve exits over their corresponding vertebral level. So for example, the C1 spinal nerve, the cervical 1 spinal nerve, goes over the cervical 1 vertebral level, vertebral body, and so on, until you have cervical 8, C8, which exits over the thoracic 1 vertebra. And this is because there is no C8 vertebra, obviously. The thoracic spinal cord is here in blue, and it has 12 pairs of thoracic spinal nerves. The thoracic spinal nerve exits below their corresponding vertebrae. T1 exits below the T1 vertebra. T12 spinal cord exits below the T12 vertebra. The lumbar spinal cord here in purple has 5 pairs of lumbar spinal nerves, exiting again below their vertebral sections. Example, you have the L1 spinal nerve exiting below the L1 vertebra. The sacral spinal cord have 5 pairs of spinal nerves, which exits through the sacral holes. Finally, you have the coccygeal nerve, which exits below the coccyx. Looking closely at the spinal cord now and the vertebrae, in more detail, we're looking at the thoracic vertebrae as an example. The spinal cord goes through the spinal canal of the vertebra. The vertebral disc sits in between the vertebrae. The spinal cord have thoracic spinal nerves coming out, here represented in blue. The spinal cord have the anterior spinal artery and 2 posterior spinal arteries supplying it. Let's look at a superior view of the thoracic spinal cord and vertebra now. Anterior to the vertebral body is the thoracic aorta. Now the thoracic aorta have posterior artery branches called the posterior intercostal arteries, which will supply the ribs. The posterior intercostal arteries branch to form the posterior spinal artery and also gives rise to the anterior spinal artery in the thoracic section of the spinal cord. Let's now focus on the spinal cord in more detail. Let's take a cross-section of the thoracic spinal cord. The spinal cord has a central butterfly-looking structure. The dorsal root at the back and the ventral root in the front will form the spinal nerve. In this case, it would be the thoracic spinal nerve. The spinal nerve then branch and can form the dorsal ramus and the ventral ramus, which essentially will supply and innervate different parts of the body. Let's now take a cross-section of the cervical spinal cord. The butterfly-looking structure in the center of the spinal cord is the gray matter of the spinal cord. The gray matter is where synapses between neurons occur. Here we can find the dendrites and the terminal axons of neurons. This is where synapses occur. The white matter surrounding the gray matter is where neurons travel through along the spinal cord. It therefore contains the neuron's axons. As we learned, the ventral root is found in the anterior aspect of the spinal cord. The ventral root of the spinal cord carries motor neurons out from the spinal cord. The dorsal root of the spinal cord carries sensory information into the spinal cord. And so here we also find the spinal sensory ganglion, where the sensory neuron's body is located. The dorsal and ventral root will form the spinal nerve. This, in this case, is a cervical spinal nerve. Let's take a look at a cross-section of the lumbar spinal cord now. The lumbar spinal cord typically has a larger gray matter. The dorsal root of the spinal cord carries sensory information. For example, information from the skin, which contains sensory nerve fibers. When touch pain is felt, these sensory fibers will carry information to a particular spinal cord level. The sensory neuron's body is at the dorsal root ganglion. The sensory neuron will travel to the posterior horn of the spinal cord. The anterior horn of the spinal cord is where the lower motor neurons arise, and they will exit the spinal cord through the ventral root and target an effector organ, for example, the muscle. To complete this section here, we have the sacral spinal cord and the coccygeal spinal cord cross-sections. Remember, the spinal cord ends at about the L1, L2 vertebral level, and this is termed the conus medullaris. Continuing bundle of fibers from here is a chordae equina. Next, let's talk about dermatomes. Your skin is innervated by sensory nerve fibers. Dermatomes are sensory nerve fibers that innervate a segment of skin and is associated with a single spinal cord level. So for example, here's a human body with a dermatomal distribution drawn out. This area in green here is innervated by spinal nerve fibers from the cervical spinal cord. The dermatome drawn in green here correlates with different sections of the cervical spinal cord. This area has sensory nerve fibers which will bring information to the C6 spinal cord level. Here is C2, C3, C4, C5, C6, C7, and C8. We have 8 cervical spinal nerves. These segments are the dermatomal distribution of the thoracic spinal cord in blue. T1 spinal cord, and so on. T10 is easy to remember because it is along the umbilical level. These segments of skin is innervated by the lumbar nerve sensory fibers. For example, this area in particular on the knee is innervated by sensory nerve fibers which will bring information to the L4 spinal cord level. The skin segment in orange is the dermatomal distribution of the sacral spinal cord levels. These include the genitals, part of the foot, but mainly the posterior aspect of the lower limb. Here's the back of the left leg. As you can see, it is innervated by the sacral spinal nerves. Important to know that S3, S4, S5 dermatome distribution is important in assessing sensation of the anus. This area is tested for sensation to see if there's any signs of spinal cord injuries. To complete this image, let's talk about the face. The side of the face here, as you can see, is innervated by C2, C3, C4 dermatomal distribution. And the front of the face is not innervated by the cervical spinal nerves, but rather they're innervated by the trigeminal nerve, which is cranial nerve number 5. After learning a bit about dermatomes and sensory nerve fibers, we can now discuss some clinical anatomy, focusing on the herpes zoster infection, also known as shingles. Shingles is a common infection. It's the reactivation of the varicella zoster virus, which is the chickenpox virus, in the sensory dorsal root or cranial nerve ganglion. It manifests in the elderly usually and is characterized by a vesicular rash along a dermatomal distribution. Shingles classically has a prodrome phase characterized by pain, burns, and sharp sensation like itching and tingling as well. This is followed by an eruption of a rash, usually unilateral, vesicular rash, which will eventually ulcerate and crust over in 10 days. Remember, it usually manifests along a specific dermatomal distribution, unilateral on one side. To understand the pathophysiology briefly, let's look at the T7 spinal cord level, which innervates the T7 dermatome segment of the skin, which is basically the upper abdomen. Shingles is reactivation of the chickenpox virus. What happens is that the chickenpox virus infects a child, characterized by vesicular, infectious, contagious rash all over the face and upper body. The virus can obviously affect the T7 dermatome, and then it can invade the area and travel along the sensory nerve fiber and essentially stay dormant in the dorsal root ganglion. Years later, when the child gets old, the chickenpox virus, also known as the varicella zoster virus, can reactivate, maybe due to immunosuppression or whatnot, but essentially it will become the herpes zoster virus, which will travel back up the sensory nerve fiber and express itself along the T7 dermatomal distribution as shingles. Here is a photograph of a person who suffers from shingles, and you can see that there is a vesicular crusting rash along the trigeminal V1 dermatomal distribution. Here is another example of a person's back, and you can see the rash, vesicular rash, is unilateral, and it affects the dermatomal distribution roughly T1 to T3 dermatomal distribution, the thoracic area. Let's talk about the blood supply to the spinal cord, which we already briefly mentioned. The spinal cord receives two main blood supply, the two posterior spinal arteries and the anterior spinal artery. These arteries run along the spinal cord. The posterior and anterior spinal arteries are branches of different arteries depending on the segment or the section of the spinal cord. So for example, the upper spinal cord, posterior and anterior spinal arteries arise from the vertebral artery, a branch of the subclavian artery. The spinal arteries also arise from the branch of the subclavian artery called the ascending cervical artery. On the thoracic level, the thoracic aorta have branches called the posterior intercostal arteries, which we talked about, that gives rise to the posterior and anterior spinal cord arteries. The lower spinal cord arteries are branches of the lumbar artery, which is a branch of the abdominal aorta, as well as the lateral sacral artery, a branch of the internal iliac artery. The artery of, I hope I pronounce this right, Adamcuits is an important artery. It is the primary supply to the lower 2/3 of the spinal cord. Essentially, if there's occlusion of the artery of Adamcuits due to ischemia, hypotension, or whatever, it can cause a person to be paraplegic. Because again, it's the main supply to the lower 2/3 of the spinal cord. Next, let's talk about the meninges, the layers that surround the spinal cord and protect it. Meninges comprise of 3 layers of protective tissue. Just like you have meninges of the brain, this continues to form the meninges of the spinal cord. Here I am drawing the spinal cord, and I will introduce the meningeal layers one at a time, from the very inner one to the outer one. And there are 3 meningeal layers. The pia mater is the inner meningeal layer surrounding the spinal cord. The second layer is the arachnoid membrane, which extends to the spinal nerve. Between the pia mater and the arachnoid membrane is the arachnoid space. The outermost meningeal layer is the dura mater. Between the dura mater and the arachnoid membrane is the subdural space. Above the dura mater is the epidural space. Now, within the arachnoid space, the subarachnoid space, you can find fluid flowing through it called the cerebrospinal fluid. The cerebrospinal fluid also flows through the central canal at the middle of the spinal cord. Cerebrospinal fluid, also known as CSF, provides the brain and spinal cord with nutrients. CSF is produced in the brain's ventricles. Let's look at the side view of the spinal cord again and understand the meningeal layers. The spinal cord ends at the conus medullaris, and the extension of the nerve fibers is the cauda equina. Then you have this thing called the filum terminale, which is basically connective tissue strand continuing on from the conus medullaris and extends all the way to basically the coccyx. The filum terminale is divided into the filum terminale internus, which is made up of continuation of the pia mater, and then you have the filum terminale externus, which is made up of the dura mater and the arachnoid membrane. The filum terminale externus ends at the coccyx. The space after the conus medullaris, below L2, is a site where cerebrospinal fluid can be accessed. This space is the subarachnoid space. A lumbar puncture is a procedure of collecting cerebrospinal fluid from the spinal canal. This is a zoomed section of the lumbar region, L2, L3, L4, and the L5 vertebra. The spinal cord ends again about the L2 vertebral level. Then you have the continuing cauda equina, the horse's tail. The pia mater ends and continues as the filum terminale internus inferiorly. The cauda equina is within the arachnoid space, floating around. The whole area is surrounded by the arachnoid membrane, and then you have the dura mater after that. The arachnoid membrane and dura mater, as we know, continue down and then envelopes to form the filum terminale externus. Above the dura mater is the epidural space. Let us progress out. Let us now look at the layers after the epidural space. First, the vertebrae is supported by many ligaments. Behind the spinal cord, you have the ligamentum flavum, interspinous ligament, then you have the supraspinous ligament. Surrounding the spinous process and the supraspinous ligament is the subcutaneous tissue, and then you have the skin. The goal of a lumbar puncture is to collect cerebrospinal fluid, which can be done by sticking a needle through the skin, subcutaneous tissue, supraspinatus ligament, interspinous spinal ligament, ligamentum flavum, dura mater, and the arachnoid membrane into the subarachnoid space where the CSF, the cerebrospinal fluid, is present. Once the needle is in this space, CSF fluid should drip out. The needle is typically inserted between the L4, L5 vertebral level to make sure it does not hit the spinal cord. A lumbar puncture is both diagnostic and therapeutic. Therapeutic because it allows intrathecal administration of chemotherapy and antibiotics, for example. Diagnostic in that it can help diagnose meningitis and multiple sclerosis. Here is an image of a lumbar puncture being performed. Note the needle in the patient's back. Most likely it's inserted between the L4 and L5 or L3 and L4 vertebral level. And note CSF dripping slowly out of the needle and being collected by a small tube. Also note the sterile field, which is important to prevent the introduction of infection to the spinal cord. Clinical anatomy. Obviously, the spinal cord can be injured. These are classically called spinal cord injuries or lesions or syndromes. Spinal cord lesions have many causes, including penetrating injuries, crush injuries, gunshot injuries, tumors, abscess, you name it. Spinal cord lesions can be divided into a few classic types. You have complete transection of the spinal cord, hemisection of the spinal cord, central spinal cord lesions, posterior spinal cord lesions, and anterior spinal cord lesions, all of which present with differing sensory and motor deficits. We won't talk about that in this video, but there will be hopefully other videos that will go into more detail. Thank you for watching this video. I hope it helped.